Welcome to our deep dive into periodontitis, a complex and multifaceted dental disease affecting millions worldwide. Today, we'll explore necrotizing ulcerative periodontitis, refractory periodontitis, and periodontitis as a manifestation of systemic disease. We'll break down their types, clinical features, risk factors, and treatment approaches. Understanding these conditions is crucial for both dental professionals and anyone concerned about oral health. Let's begin by setting the stage with a brief overview of periodontitis and why it's important to recognize its various forms. Necrotizing ulcerative periodontitis, or NUP, is a severe form of periodontal disease. It arises when necrotizing ulcerative gingivitis extends deeper into the periodontal structures, resulting in loss of attachment and bone loss. NUP is characterized by rapid tissue destruction, often leading to deep, crater-like lesions. Unlike conventional periodontitis, NUP does not present with deep pockets, but rather with extensive tissue necrosis. Recognizing NUP early is vital for preventing irreversible damage and guiding appropriate treatment. NUP is classified into two main types, based on its association with acquired immunodeficiency syndrome: AIDS, non-AIDS type NUP, and AIDS-associated NUP. The distinction is important because the clinical presentation and complications can vary depending on the patient's immune status. Non-AIDS type typically results from repeated attacks of NUG, while AIDS-associated NUP often presents with more severe tissue destruction and additional complications. Understanding these types helps clinicians tailor their diagnostic and therapeutic strategies. Non-AIDS type NUP emerges after repeated episodes of necrotizing ulcerative gingivitis. Clinically, it displays all features of NUG, including necrosis of the gingival margin, pseudomembranous slough, and erythematous margins. Patients may experience unilateral lymphadenopathy, fever, and malaise. Over time, lesions can extend into deeper periodontal structures, forming deep, crater-like osseous lesions, especially in interdental areas. The hallmark is the absence of deep pockets, replaced by destructive craters due to the necrotizing nature of the disease. AIDS-associated NUP shares many features with the non-AIDS type, but is often more severe. In HIV-positive patients, large areas of soft tissue necrosis are common, sometimes exposing bone and leading to sequestration of bone fragments. These lesions may extend onto the buccal vestibule or palate, evolving into necrotizing stomatitis. The immune compromise in AIDS patients exacerbates tissue destruction, making early intervention and specialized care essential. To summarize, necrotizing ulcerative periodontitis results from the extension of ulcerative gingivitis into deeper periodontal structures, causing attachment and bone loss. It can be classified as either non-AIDS type or AIDS-associated, with the latter presenting more severe tissue necrosis and bone exposure. Recognizing the differences between these types is crucial for diagnosis and treatment planning. Early intervention can prevent further destruction and improve patient outcomes. Treatment for necrotizing ulcerative periodontitis involves local debridement of lesions, scaling, and root planing. Good oral hygiene instructions are essential, and ultrasonic instrumentation with copious irrigation is often used. Topical antimicrobials, systemic antibiotics, and analgesics may be prescribed to alleviate pain and control infection. The goal is to remove necrotic tissue, reduce microbial load, and support healing. Individualized care is important, especially for immunocompromised patients. Moving on. Refractory periodontitis is a challenging condition defined by the American Academy of Periodontology as cases that do not respond to any treatment, regardless of thoroughness or frequency. It is important to differentiate refractory periodontitis from recurrent periodontitis, which occurs due to inadequate plaque control after remission. Refractory cases remain resistant despite optimal therapy, and their underlying causes are not always clear. Several risk factors contribute to refractory periodontitis. These include abnormal host response, resistant strains of pathogenic periodontal microflora, and failure to eliminate plaque-retentive factors such as furcation involvement or irregular root surfaces. Smoking and systemic diseases can also play a role, leading to generalized lesions that are difficult to treat. Specific microorganisms like Bacteroides forsythus, Fusobacterium nucleatum, and Campylobacter rectus have been identified in refractory cases. Research has identified 3 major microbial complexes in refractory periodontitis: Bacteroides forsythus, Fusobacterium nucleatum, and Campylobacter rectus, Staphylococcus intermedius, Porphyromonas gingivalis, and Peptostreptococcus micros, and C. intermedius with F. nucleatum. These bacteria are often resistant to conventional therapy, making eradication challenging. Understanding the microbial landscape is essential for developing targeted treatment strategies. Clinically, refractory periodontitis is identified by new areas of attachment loss or progressive loss in already treated sites. Persistent bleeding on probing is common, and affected sites may show no change in plaque levels despite treatment. The American Academy of Periodontology has removed refractory periodontitis as a single entity due to its diverse clinical presentations. Instead, the term refractory can be applied to all forms of periodontitis that do not respond to therapy. It's important to distinguish between recurrent and refractory periodontitis. Recurrent periodontitis refers to sites successfully treated but where disease returns, often due to inadequate maintenance. Refractory periodontitis, on the other hand, involves sites that do not respond to conventional therapy, possibly due to tissue-invasive microbes or immunoincompetence. Antibiotic therapy is usually needed for refractory cases, while recurrent cases may not require it. Refractory periodontitis is defined as cases that do not respond to any treatment, regardless of thoroughness or frequency. It must be differentiated from recurrent periodontitis, which recurs due to inadequate plaque control. The American Academy of Periodontology no longer recognizes refractory periodontitis as a single entity, instead applying the term to any form of periodontitis resistant to therapy. This distinction guides clinicians in diagnosis and management. Treatment for refractory periodontitis involves antimicrobial therapy combined with mechanical debridement. Antibiotic therapy reinforces mechanical periodontal treatment and helps eliminate subgingival pathogens. Intrasulcular irrigation with povidone iodine or chlorhexidine solutions has been used successfully. Local drug delivery systems, such as gels, fibers, or chips, offer smaller doses and minimal side effects. Host modulation with sub-antimicrobial doses of doxycycline or NSAIDs may also be beneficial. Several antibiotics are used to treat refractory periodontitis, including tetracycline, hydrochloride, amoxicillin, clindamycin potassium, and augmentin. Combination therapies, such as metronidazole with amoxicillin or doxycycline, are also effective. Dosages are carefully tailored to minimize side effects and maximize efficacy. The goal is to reinforce mechanical therapy and support the host defense system in eliminating persistent pathogens. Host modulation is an innovative approach in treating refractory periodontitis. Sub-antimicrobial doses of doxycycline help prevent periodontal destruction by controlling collagen and gelatinase production. NSAIDs like flurbiprofen, indomethacin, and naproxen reduce inflammatory mediators during chronic periodontal disease. These therapies complement conventional treatment, offering additional protection against tissue breakdown. Severe periodontitis can be a manifestation of systemic diseases, particularly those affecting neutrophil number or function. Conditions like Papillon-Lefèvre syndrome, Chidiac-Higashi syndrome, Down syndrome, hypophosphatasia, neutropenia, and leukocyte adhesion deficiency are associated with severe periodontal destruction. Understanding these associations is vital for comprehensive patient care. Papillon-Lefèvre syndrome is an inherited autosomal disorder characterized by calcification of the dura, abnormal bone formation in hands and feet, and severe periodontitis. Permanent teeth erupt normally, but are lost within a few years due to early inflammatory changes and rapid periodontal destruction. Primary teeth are typically lost by age 3 to 6. Recognizing this syndrome is crucial for early intervention and management. Chidiac-Higashi syndrome is a rare hereditary disease with defects in both neutrophils and monocytes. It is characterized by recurrent bacterial infections, oral ulceration, and rapidly destructive periodontitis. Patients may also experience photophobia, recurrent respiratory and sinus infections, and neurological or gastrointestinal disturbances. Early diagnosis can help manage symptoms and prevent severe oral complications. Down syndrome, also known as trisomy 21, is a congenital disease marked by mental deficiency and growth retardation. Oral findings include plaque, calculus, diastema, crowding, high frenal attachment, and malocclusion. Periodontitis in Down syndrome often presents as deep pockets, moderate gingivitis, and marked recession, especially in the lower anterior region. Acute necrotizing lesions are also common, highlighting the need for vigilant oral care. Two main factors explain the high prevalence and severity of periodontitis in Down syndrome: reduced resistance to infections due to poor peripheral circulation, and defects in T-cell maturation and polymorphonuclear leukocyte chemotaxis. These immune deficiencies make patients more susceptible to severe periodontal destruction, emphasizing the importance of preventive care and regular monitoring. Hypophosphatasia is a rare familial skeletal disease characterized by rickets, poor cranial formation, and premature loss of primary dentition, especially incisors. Patients have low serum alkaline phosphatase levels, and teeth are lost without clinical evidence of gingival inflammation. Reduced cementum formation is a hallmark. There are juvenile and adult forms, with the adult form limiting destruction to the incisor region. Neutropenia is a condition where circulating neutrophils are reduced to less than 1,500 ml. Children with neutropenia often develop destructive, generalized periodontal lesions. The condition can be inherent or acquired, with certain drugs and infections leading to reduced neutrophil numbers. Early recognition and management are essential to prevent severe oral complications. Leukocyte adhesion deficiency is a rare condition that begins during or immediately after eruption of primary teeth. It is marked by extreme acute inflammation, proliferation of gingival tissues, and rapid bone loss. Profound defects in peripheral blood neutrophils and monocytes are observed, leading to their absence in gingival tissues. Patients often suffer frequent respiratory infections and sometimes otitis media. Many systemic conditions associated with defective neutrophil number or function exhibit severe periodontitis. These include Papillon-Lefèvre syndrome, Chidiac-Higashi syndrome, Down syndrome, hypophosphatasia, neutropenia, and leukocyte adhesion deficiency. Recognizing these associations is essential for comprehensive diagnosis and management, as oral manifestations may be the first sign of underlying systemic disease. Early diagnosis of periodontitis, especially when associated with systemic diseases, is crucial for preventing irreversible damage. Dental professionals should be vigilant for signs of severe periodontal destruction, particularly in patients with known systemic conditions. Timely intervention can improve outcomes and quality of life, highlighting the importance of regular dental checkups and interdisciplinary care. Maintaining good oral hygiene is fundamental in preventing and managing periodontitis. Regular brushing, flossing, and professional cleanings help control plaque and reduce the risk of disease progression. Patients with systemic conditions or refractory periodontitis require tailored oral hygiene instructions and close monitoring to ensure optimal outcomes. Scaling and root planing are essential procedures in treating periodontitis. These mechanical therapies remove plaque and calculus from tooth surfaces and roots, promoting healing and reducing inflammation. Ultrasonic instrumentation may be used for more effective debridement, especially in cases of necrotizing ulcerative periodontitis. Topical antimicrobials such as chlorhexidine and systemic antibiotics are often used to control infection in periodontitis. These agents help reduce microbial load and support healing, especially in severe or refractory cases. The choice of antimicrobial depends on the clinical scenario and patient-specific factors. Local drug delivery systems, such as gels, fibers, or chips, offer targeted therapy for periodontitis. These systems deliver smaller doses of medication directly to affected sites, minimizing side effects and maximizing efficacy. They are particularly useful in localized lesions and refractory cases, providing an adjunct to mechanical therapy. Host modulation strategies, including sub-antimicrobial doses of doxycycline and NSAIDs, are increasingly used in periodontitis management. These therapies aim to control the host's inflammatory response and prevent tissue destruction. By complementing conventional treatments, host modulation offers additional protection and improved outcomes for patients with chronic or refractory disease. Pain management is an important aspect of periodontitis treatment. Analgesics may be prescribed to alleviate discomfort during and after debridement procedures. Ensuring patient comfort supports compliance with treatment and improves overall outcomes. Individualized pain management plans are essential, especially for patients with severe or necrotizing lesions. Managing periodontitis, especially when linked to systemic diseases, requires an interdisciplinary approach. Collaboration between dental professionals, physicians, and specialists ensures comprehensive care. This approach is particularly important for patients with immune deficiencies or complex medical histories, as oral manifestations may signal broader health issues. Educating patients about periodontitis and its risk factors is vital for prevention and management. Patients should understand the importance of oral hygiene, regular dental visits, and adherence to treatment plans. Those with systemic conditions require additional guidance to recognize early signs of periodontal disease and seek timely care. Regular monitoring and follow-up are essential for patients with periodontitis, especially those with refractory or systemic disease. Dental professionals should track disease progression, response to therapy, and compliance with oral hygiene instructions. Early detection of recurrence or resistance allows for timely intervention and adjustment of treatment strategies. Genetic factors play a significant role in the susceptibility to periodontitis, particularly in syndromes like Papillon-Lefebvre and Shediac-Higashi. Understanding genetic predisposition helps identify at-risk individuals and guide preventive strategies. Genetic counseling may be beneficial for families with inherited syndromes linked to severe periodontal disease. Smoking is a major risk factor for refractory periodontitis and can lead to generalized lesions that are difficult to treat. It impairs healing, alters immune response, and increases the risk of disease progression. Smoking cessation is strongly recommended for patients with periodontitis to improve treatment outcomes and overall oral health. Managing systemic diseases associated with periodontitis requires a holistic approach. Addressing underlying conditions, such as immune deficiencies or metabolic disorders, supports oral health and reduces the risk of severe periodontal destruction. Coordination between healthcare providers ensures optimal management and improved patient outcomes. Advances in periodontitis care include new antimicrobial agents, host modulation therapies, and personalized medicine approaches. Ongoing research aims to better understand the microbial landscape and genetic factors influencing disease susceptibility. These innovations promise improved prevention, diagnosis, and treatment strategies for all forms of periodontitis. In summary, periodontitis encompasses a range of conditions, from necrotizing ulcerative forms to refractory and systemic disease manifestations. Early diagnosis, tailored treatment, and interdisciplinary care are essential for managing these complex cases. Understanding risk factors, microbial profiles, and host responses guides effective prevention and therapy. Periodontitis is a multifactorial disease requiring comprehensive management. Key takeaways include the importance of early detection, differentiation between disease types, and the role of systemic conditions. Patients and clinicians must work together to ensure optimal oral health through preventive care, targeted therapy, and ongoing education. For those interested in learning more about periodontitis and its management, numerous resources are available. Dental textbooks, professional guidelines, and online courses offer in-depth information. Staying updated with current research and clinical recommendations ensures the best care for patients with periodontal disease. Preventive care is the cornerstone of periodontitis management. Encouraging regular dental visits, proper oral hygiene, and healthy lifestyle choices can significantly reduce the risk of disease progression. Patients should be empowered to take charge of their oral health and seek professional advice when needed. As we conclude our exploration of periodontitis, remember that this disease is complex and often linked to broader health issues. Early recognition, tailored treatment, and ongoing education are key to successful management. By staying informed and proactive, both patients and clinicians can work together to achieve better oral and overall health. Thank you for joining us on this comprehensive journey through periodontitis. We hope this information empowers you to make informed decisions about oral health and encourages ongoing learning. Stay tuned for more educational content on dental and medical topics.